Good morning, ladies and gentlemen. At the outset, I'd like to thank Dr. Devan for this invite. I sincerely appreciate the honor and the opportunity. So, like he told you, what should I do? My patient has an IOP of 24 millimeters of mercury in one eye. Well, I'm sure most of you have gone through the absorbing abstract which Dr. Devan has written, where the patient comes to the clinic and is very confused for an annual checkup whether he has glaucoma. So taking it all from there, the story so far, the salient points there are that he's come for an annual checkup. Every time he hears, I think you have glaucoma. And for 11 years, he's been on and off glaucoma medications, and this time he's on his 12th annual checkup for glaucoma. So yesterday was a fact for him. He didn't know whether he had glaucoma or he didn't have glaucoma. Tomorrow is a possibility. He might be diagnosed with glaucoma tomorrow. And today is the crunch, the challenge, where he would actually know what happens tomorrow. So today actually makes tomorrow, and that's true for every scenario in life. So going back to the point, is that the patient has an IOP of 24 millimeters of mercury in one eye. What should I do? Well, I would proceed with checking the intraocular pressure once again for my satisfaction, and as he said, there are certain protocols which we need to follow when we're treating a glaucoma patient. I would definitely like to see that pressure on the Goldman applanation tonometer, not on any of the others, because that's the gold standard for measuring the intraocular pressure till date. So if you're using the Goldman applanation tonometer, you all know this, for the sake of theory, is that you need to correct it for the CCT, and it was found that 5 millimeters of mercury for every 70 micron of change in CCT, that is the normal nomogram which is followed. And basically you can have extremes of underestimation and overestimation about 12 millimeters of mercury if you actually do not correct your Goldman applanation tonometer for the CCT. So we stand at a point where after using the Goldman applanation tonometer for almost half a century, we need to correct it for the central corneal thickness. So now we move on to the other associations. IOP alone cannot justify treatment at any point. So what are the other associations which we need to see? In IOP itself, we need to see the diurnal variation. Next comes, it could be drug-induced, family history, which my previous speaker just spoke about, gonioscopy, which Dr. Kamar has highlighted, disc evaluation, which would come later on, automated perimetry, the gold standard for functional test, and the structural tests which are there today, the imaging techniques. So let us move on one by one. The intraocular pressure, diurnal variation. What we generally do nowadays is we see the office IOP or the random IOP. Research extensively done by Asrani, Kitawaza and Browns have showed that large proportions of positively screened eyes in the morning would have been missed in an afternoon detection clinic because of a fall-off in pressure towards the later part of the day. So diurnal variation is actually that important. And if you look at this graph here as well, there is a great difference in the IOP. This is the diurnal, the wake period, that's the nocturnal sleep period, and that's again the diurnal variation. So during the sleep period, as it is, IOP is high in the supine position and at night, so definitely there is a fluctuation in IOP. So a 24-hour study in patients known to have progressive glaucoma revealed that peak measurements were averaging between 5 to 12 millimeters of mercury, apart from the office visits, and that's depicted on this graph that you see out here. So IOP fluctuation, as we all know, causes visual field progression, so that's a very important factor which you need to rule out. Drug-induced, well, steroids, but in this case, it's high IOP in one eye, so it's generally bilateral if it's drug-induced. But even then, you never know, the patient could have been taking some steroid drop in one eye particularly, so you need to take the history in detail. Topiramate, as you all know nowadays, is given for migraine. Sometimes you don't even know the patient is taking it and suddenly lands up with acute congestive glaucoma, but that's also bilateral, and benzodiazepines have always added to it. family history, which was just spoken in very good detail by my previous speaker, but just to run through it, does ethnicity influence glaucoma prevalence? Yes, it does, and your patient's background may put them more at risk. But like you also said, to do a genetic examination, you can do a molecular genetic studies have been there, a number of them from our country, but that it is extremely expensive, but it can be done. And if you go to the other side of the story, that's the environment, socioeconomic status, cultural differences like consanguineous marriages, which are common in certain parts of the country. And if you look at those prevalence studies, which he spoke about, they would actually reveal to you maybe you could have pseudo-exfoliation, which is common in tropical and ambient temperatures, and that would give rise to a higher IOP. So you need to rule out all that. Next again is the genetic part of it. The pathophysiology is unknown, but suggested that MYOC protein obstructs the outflow of aqueous humor through the trabecular meshwork, resulting in increased IOP, which is frequently associated with glaucoma. So family history, if there is a positive family history with a pressure of 24 millimeters of mercury, I would definitely follow up that patient. Gonioscopy, Dr. Kamar has very beautifully told you everything about it. Well, I just add to that you definitely need to see the trabecular meshwork. You need to visualize the trabecular meshwork if you have to rule that patient out from any kind of an angle suspect. And if it's a closed angle, well, definite treatment is recommended. Now to come to the optic disc. Well, there are 100 different types of normal optic discs, so that's a very confusing picture. But any deviation from the customary, like isn't rule or bayoneting of vessels, anything like that, you need to actually follow up the patient. And if you have a blatant picture like this, then you definitely know it is the beginning of sundown. Next we move on to automated perimetry. Automated perimetry, well, FDT is a wonderful screening tool. We use it at the Peripheral Center for our prevalence studies, and it can really give you at least an inkling into which are the patients which need to go for standard automated perimetry. So they go for standard automated perimetry. I'll always remember it's always first standard automated perimetry and then swap shortwave automated perimetry if standard automated perimetry is within normal limits. The structural tests, well, the GDX, VCC, the OCT, and the HRT3, all of them have different areas basically. The OCT takes care of the ganglion cell thickness and the retinal nerve fiber layer. The HRT is more related to the disc. But mind you, I wouldn't treat a patient based on these. I would definitely clinically correlate the patient with other features, and then only I would start treatment. So if you look at this graph, it's extremely interesting, and that's the reason I put this on. This is 756 individual intraocular pressure measurements over a period of about 77 seconds obtained by the Pascal dynamic continuometer. So these are the graphs, and you can see that the first three waves averaged together represent a valid IOP towards the middle. And the level of that peak actually becomes the graph in this lot of graphs that has been taken. So that actually brings home to us that IOP increased at least 4 millimeters of mercury in about 40 seconds. So that's to bring home that IOP fluctuates. So making sense of IOP fluctuations is very important, and for that the target IOP that I would limit myself to would be this. Keeping in mind that the ocular hypertensive study said that 50% of ocular hypertensives actually did not progress to glaucoma. So if my patient has only 24 millimeters of mercury with no other signs, in that case I'll just advise the patient to come for an annual examination with a free mind and just carry on with that. If my patient has other diagnostic tests positive along with the high pressure, I would go for all these. I would help him, I would support him, I would teach him to use the drops regularly, I would guide him. Glaucoma is not cancer, you need to treat the disease chronically, and encourage him, because when you are always worried about the future, you forget actually to live in the present, and that's true for each one of us. Thank you for your attention.